Hi, I'm Dr. Phil Memoli, and I'm here today to discuss jawbone cavitations. What exactly is a jawbone cavitation? A lot of people would define them as a chronic infection in the bone. Issels, who was a cancer researcher, he called chronic bone infections, particularly of the jaw, he called them foci. He can be quoted as saying, the foci of the mouth are the most lethal of all. It raises the question, here is something that there's no pain, there's no overt sign of infection, there are no laboratory markers, there's no clinical markers, there's no x-ray that can diagnose these. How can we prove evidence of existence? How can we prove evidence of harm? These are great questions around this idea. And it's interesting because a study was done by the CDC, and DiStefano was the main author. His study is a landmark study because this was not a retrospective study. This was a prospective study. And the prospective study is considered to be the gold standard for studies. He found increased risk of morbidity and mortality for people who have periodontal infections and missing teeth, i.e. teeth that had areas of chronic infection in them. Here was an amazing study on a topic that is considered controversial, that it's extremely difficult to diagnose, it's even harder to treat, and 99% of the dental profession denies that it exists, possibly. And here's a study saying, yes, it's there, and we need to pay attention to this. How do we get these cavitation jaw infections? What does chronic mean? Basically, how can you have an infection in your jaw and not know it? Well, if you have an infection and you know it, we call that an acute infection. It's acute because it hurts. Chronic implies chronos. Chronos is time. So it means it's an infection over time and there's usually no symptoms. This is understood and acknowledged by the medical profession. We know that they're chronic infections. They're there, but they don't hurt us. And again, the key question is, if they're not hurting us, are they harming us in another way? And this is one of the main areas that we have to look at. How is it caused again? A recent study was published in the Academy of General Dentistry journal saying that 3% of wisdom teeth are indicated to be extracted. Now, it's more the case that 97% of wisdom teeth are probably being extracted. But this article was saying that the indications, the reason to pull a tooth, a wisdom tooth, is only 3%. Why are wisdom teeth mostly being pulled? They're being pulled because orthodontists, dentists are telling patients that if you don't remove the wisdom teeth, the teeth are going to become crooked. Well, studies have been done, and it's been shown that whether you remove the wisdom teeth or you don't, the teeth still get cluttered. The teeth still get crowded. So pulling the wisdom teeth it's not going to change whether you get crowding later. That's not an indication to pull. Impaction is not a reason to pull. Impaction simply means the teeth are trapped. It doesn't mean they're infected or inflamed or they're causing a problem. It means more than likely they will not be able to come out. So again, impaction is not an indication to extract wisdom teeth. Neither is fear of crowding. How is a chronic infection site created? Well, when we pull wisdom teeth, the wisdom teeth are roughly, matter of fact, almost all teeth are roughly the size of a bullet. So pulling 4 teeth at once is the rough equivalent of having 4 bullet holes in your jaw. How well is the body going to heal from that? If you had 4 bullet holes in your jaw, you would be in the hospital for a month or two. We're taking the teeth out, we're excusing people, and we're expecting nature to be able to heal this. Around each tooth is a ligament. Generally, when the tooth is pulled, the ligament is left there with the idea that the ligament will just dissolve. One of the issues with ligaments is that when the tooth's pulled, the bone cells on the outside, if they go and hit the ligament, they stop. So we don't get, in some cases, we won't get complete bone healing. It's probably true that with time, that ligament will dissolve. Over the long term, what variables are going to determine if that bone heals? Dietary is going to be high. The person's health is going to be high. What's happening when you have the wisdom teeth pulled out? You're on antibiotics, that's draining the body, that's killing a lot of your bacterial flora. You're on pain medication. This is going to interfere with healing also. So the odds are that the site is going to be interrupted in its healing. It's 4 sites and there's a lot of bone to heal. Okay, once that tooth's pulled, there is no bone matrix that gets filled. The body has to figure out how to heal that hole where there wasn't bone previously. Once there's the hole in the bone and that bone doesn't heal, what is going to be attracted to a hole in the bone? Probably bacteria, okay? And what's not going to be in that site? Blood. So now we have bacteria in a hole in the bone that blood can't get access. So now the immune system can't, with its T cells and B cells, can't actually get in here and start the process of dealing with this infection. Now you're going to have bacteria, presumably including Borrelia and other spirochetes. This could act as a hiding place for bacterial infection. So think about it. You have Lyme disease or you have some sort of other infection. You take antibiotics or you take herbals. The environment in the blood becomes difficult for these bacteria to survive. They can go into this hole and survive. When the coast is clear, when you stop taking these meds, they come out again. Begins a cycle where medical therapy doesn't work. We call these refractory infections. Now that we've established that we have a hole in the bone and it's not healing and that there's bacteria in here, what is the next step? The next step is that these bacteria, and more so, they're toxins, because bacteria, when they eat, they essentially release toxins. And when we kill these bacteria, there's certain types of bacteria like gram negatives. These type tend to release all their toxins into our bloodstream. The immune system has to deal with this bacterial load. It has to deal with this toxic load. And then while it's dealing with it, it's creating all these inflammatory products around there. And then these inflammatory products that are supposed to be left in the jaw now spill over into the blood. This can create systemic inflammation. What organs are most susceptible? Heart, lungs, pancreas. These are organs that are challenged with other chronic degenerative diseases. It puts significant stress on the body. People undergoing medical care for these particular organs, we have to ask the question, what's the cause? If the underlying cause is a systemic infection coming from the mouth, that has to be addressed. How can we diagnose something that there's no laboratory markers, no x-rays will find it, and there's no laboratory markers for this? The idea here is, why can't x-rays find it? Well, if you think about this, it's almost like a chicken bone. If you broke a chicken bone in half, you would see that the outer compartment is solid bone, and on the inside is the soft marrow. That's the exact same situation we have in our jawbone here. There's 2 thick outer layers of basically dense bone, and on the inside is the marrow. When an x-ray is taken of that, The denser part of the bones absorbs almost all of the radiation. Some people have said digital radiography can pick this up, or 3D CAT scans can pick this up. The way that digital radiography actually works is when you take a real film, an analog film, that film takes an actual picture and you have to interpret it. Digital, you're taking a picture and the computer is interpreting it. And the computer is interpreting it and it's presenting the picture that it thinks is there. Not the actual picture, but the picture it thinks is there. And it does this through algorithms. So an algorithm has to be written into the computer program to find these lesions, to find these infections. For an infection that, according to 99% of the dental profession, does not exist, who's writing such an algorithm that we can diagnose something that doesn't fit? There is a person working on this, but I'd have to say there isn't anything out there that diagnoses this right now. There was a machine called the Cavitat. It was ultrasound, so it was sending waves through there that were bouncing, and that accurately assessed cavitation sites and found them in the jaw. In an FDA study, it was found to be highly accurate. The company went out of business. The machine no longer exists. We can't get parts and equipment for it, so we no longer have these machines. There's a handful left in the country. What are we left to diagnose this? Again, you cannot diagnose this with 3D CAT scans or x-rays. So basically what's left to us is acupuncture. Acupuncture will give us a diagnostic assessment of this. History will give us a diagnostic assessment of this. These are the two main things that we have to go by. If in the history there was a very difficult extraction with a lot of pain and bleeding and swelling, that might be indicative that it healed with a chronic infection. The other thing would be, as I stated earlier, is a series of chronic medical problems that can't seem to resolve themselves. Those tend to indicate that there is the possibility of there being a chronic dental infection. When it comes to treatment, the current standard of care is to scrape the bone for 5 minutes, okay, drill 1 millimeter past the existing bone that's there, and to put someone under, to knock someone out, to put them under general or a short-term general anesthesia. And if you remember, our goal is to grow bone. Our goal isn't just to open up the site. Our goal is ultimately to grow bone. From a scientific point of view, scraping for 5 minutes or 15 minutes for that matter doesn't really have any scientific validity because we don't know what we're scraping. Drilling 1 millimeter, one might find bone infections that go on for 5 millimeters, even 12 millimeters. So 1 millimeter is not a good guide. The anesthesia, the general anesthesia, seems to interfere with bone growth later. And it puts a lot of taxing on the liver, okay, which may actually even cause it to not heal. So these are not things that I recommend. How do we create guidelines for this? Well, the goal here is, in my opinion, based on my understanding of biological medicine, the acupuncture meridians, as I had discussed in biological dentistry, these meridians are the communication channels and the healing channels. Once the infected bone material is removed, the acupuncture meridian should come back on. It should go back to normal function. So the body itself tells us when we've achieved a state where it can now assist us with the healing. So if the meridian is not open, there will not be healing. There will not be any bone healing. We need energy. We need the brain to be aware that there is a site there. The nervous system, the meridian system, these all have to be turned back on to get a comprehensive type of healing. It doesn't matter if you're using ozone or if you're using vitamin C drips. That's not going to produce long-term healing. Osteogenesis is something that goes on for 3 or 4 months. So in essence, we need some way to maintain or evaluate the healing for 3 to 4 months. What's effective here is to evaluate the person before. We'd have to assess how their clotting is doing, how their mineralization is doing, how their diet is. These things all have to be assessed because these are essential elements in terms of long-term healing. At the surgical time, the site is open with conservative incisions. In terms of pain later, when a conservative approach is taken, there's a lot less pain later, almost to the point where you can just take arnica to control the pain, or some people just take 1 or 2 Advil, and that's the extent of the pain relief that's needed. During the surgical procedure, after the bone is removed, the key question is, what do I put in that site? Do I get a clot from the patient in terms of protein-rich plasma or protein-rich fibrin? Do I obtain that before, okay, to assist me? Do I let the person clot by himself? Do I put a bone graft in? If I put a bone graft in, do I use human bone, or do I use autogenous bone, which would be taken from the person's jaw? So I'd like to look at each one of these specifically. These are important questions. It's become the standard of care to use an artificial clot, meaning one taken from your blood and then spun. Now, medically, there are a lot of people who don't form good clots. So even though the blood fills in the sockets, they may not get a good blood clot. So the idea came about, let's spin the blood and form a blood clot and put it in there. And the idea was that this would not only help clot it, but it would help create bone. And the problem was the early studies. The early studies were not very accurate. There might have been problems with the way they were designed, but the early studies did give us some hope that this would be a great way to heal these sites, especially in some sites where people couldn't get good clots. The research that's in, and it was cited by a researcher at a 3-day implant conference. The review of the literature showed that these clots, were not only not forming bone, but might be interfering with bone growth. And they found that what the bone clots were actually, what these new clots were actually doing was helping the gum tissue heal well. So when doctors looked into the mouth and they saw that it looked like it was healing well, it was because it was assisting the soft tissue, the gum tissue, to heal. But it wasn't doing anything for the bone, and it might have been hampering the bone. So placing these artificial clots, these spun clots, is not only not forming bone, but might be interfering in the process of us making bone. So these are not things that I'm suggesting. They're increasing the price, and it looks like it's lowering our success rate. So the question becomes, what should we put in the bone site? Well, there are a couple options. The jury is still out. I'm not here to say that this is the best way to do it, but there is the option of bone grafts. There are bone grafts from your own body, which could be taken in sites nearby. You could put live bone in there, and that heals fine. But what's the problem? Now you have 2 sites that have to heal instead of 1, and you're back to first base, having a lot of sites that have to heal. The other choice is, if you don't create another site, you can put cadaver bone in there. And cadaver bone, the benefit of cadaver bone is it will not block the meridian, which is amazing. The downside of the cadaver bone is you may form bone in there that is not vital. So you may have actual physical bone, but it may not have blood flowing through it. So that could be a potential problem down the road. So these are some of the major issues with cavitation surgery and how it's being performed. The final issue here is long-term bone healing. What seems to be necessary is that once the patient walks out the door, the surgery is done, and that's half the battle. Now the healing has to occur. And whose responsibility is that? If there is no follow-up, there will not be any healing. But the question is, what follow-up? So one follow-up is definitely to monitor mineralization in the body. Another is to monitor the acupuncture meridians. But at the end of the game, what we're looking for is osteogenesis, which means complete or almost complete bone growth. How can we, as dental surgeons, expect healing to occur naturally? How can we expect to put a bullet hole in their jaw with our surgery? The body at age 30 is losing bone. What do we expect the body to do at age 40 or 50 or 60? A lot of my colleagues believe that osteogenesis, new bone growth, happens automatically and happens when you do this simple cavitation surgery. Doing the surgery in a different way doesn't always necessarily mean that you're going to heal properly. That has to be planned from the beginning. There has to be a lot of patient assessment, and this is a controversial and difficult aspect, and it requires a lot of patient education. And we look forward to discussing this subject further with you.